Good morning, everyone. Thank you again for joining us this morning. My name is Brooke Thomas. I'm your CME specialist with Community Hospital. Today we have Dr. Nick Monson from the University of Utah presenting to us on management options of chronic knee pain. A few housekeeping items before we start. If you have any questions for Dr. Monson, please add those to the chat and we will answer those throughout the presentation. Dr. Monson has a disclosure that he is a consultant for Ivanos Medical, and this has been mitigated. Community Hospital designates this program for a maximum of 1 AOA Category 1A credits and will report CME and specialty credits commensurate with the extent of the physician's participation in this activity. Community Hospital also designates this live activity for a maximum of 1 AMA PRA Category 1 credits. Again, physicians should claim only the credit commensurate with the extent of their participation in the activity. Dr. Monson went to med school at Des Moines University and completed his residency in family medicine at the University of Utah. He completed his sports medicine fellowship at the University of Utah, graduating in 2014. Dr. Monson completed 2 years with Davis Orthopedics prior to returning to the University of Utah to join the Ortho Group and Sports Medicine Fellowship faculty in 2016. Dr. Monson serves as a team doc for the University of Utah football, lacrosse, Utah Jazz, Salt Lake Community College, as well as the director of orthopedics for the Farmington Health Center and provider at the Snowbird Medical Clinic. Dr. Monson has 3 children and an awesome wife. He is an outdoor sports enthusiast with active research interests in concussion and usage of cell therapies, primarily focusing on PRP. Okay, Dr. Monson, the floor is yours. Thank you.
Appreciate it. Okay, so today we're going to go over management options for chronic knee pain. Kind of give you an update on what's expanding. It's a ever expanding field. There's always exciting new treatment options for this, and as you already heard, but feel free to interrupt at any point if you have questions or comments. And I don't think my last slide has anything about my email or cell phone number, but I'll just state it so that you can always reach out if you have any questions or anything I can help you out with. The knee, I'm sure all of you have seen a lot of this. My understanding is that this group is primary care. Is that correct?
Yes.
Okay, awesome. So everybody gets to see lots of knee pain then, because it is very common. 1/5 of people in America over the age of 45 will begin to develop some knee osteoarthritis. And it's the largest synovial joint in humans. Risk factors for developing that arthritis directly relate to age. There's an obesity component, a trauma component, a little bit more common in postmenopausal female with changes, some malalignment discrepancies that can contribute, and then genetic characteristics. So people often ask, like, how come this is happening to me? And the answer is always it's very multifactorial. There's a lot of things that contribute to it. Oh, yes, my disclaimer. Sorry, that should have been the last slide. But I do have this existing contracts with both Trice Medical and Avanos Medical. I won't mention either one of those during this lecture today. Radiographically is one of the ways that we diagnose osteoarthritis. It's kind of been one of the standards that we've used for a long time. The Kellgren-Lawrence grading scale is kind of the standard of how we will discuss it. But in the end, osteoarthritis is so much more than just what an X-ray is. So I often tell people, hey, I use an X-ray to help guide me on what I'm discussing as your treatment options, because a lot of our research is based off of the level of osteoarthritis present, but it also involves more than that. On X-ray, there's 4 characteristics you're looking for. One is joint space narrowing. The second is subchondral sclerosis, which is kind of that white scarring appearance that you'll see underlying a bone when there's more arthritis developed. The other part is that you'll develop spurs. And then the final part is that you'll develop cysts within the bones. And so as the arthritis progresses, you might see all of those components present on imaging. Um, the way that I explain it to patients in clinic is that I'll say, hey, the end of a bone is capped with cartilage. It's just a smooth surface that lets one bone glide across another bone. But in the setting of osteoarthritis, we start to maybe get some potholes or it gets a little bit more pocked on the ends of those bones so that no longer do those bones move smoothly across each other. And that's a helpful conversation because people come in often asking about mechanical symptoms. They get popping and catching in their knee because the meniscus is starting to get involved. And that helps them to understand different treatment options that are available for those symptoms, but also understanding the limitation of some of those options because the ends of the bones at the end of the day are going to cause some irritation to that meniscus because they're no longer smooth. On the radiographs, we will obtain a AP of the knee, and then we'll get a PA flexion where patients bend their knees to about 20 degrees. That really helps show the joint space a little bit more accurately. We'll get a lateral, helpful to look for effusions and address the patellofemoral space. And then sometimes you can see little articular loose bodies that are hanging out in different recesses of the joint. And then a merchant view or sunrise view is always helpful to get a better view of the patellofemoral space. So we do end up doing a fore-view of the knee. A good diagnosis is important. There are people that come in that have pretty significant osteoarthritis on their imaging, and their pain is not from their osteoarthritis. Their pain is from something else, whether it be the patellar tendon or just patellofemoral pain syndrome. The PES answering sometimes will have a bursitis associated with that, IT band, popliteal tendon strain. There's a lot of things that can contribute. So making sure that you don't just see a radiograph and say, well, that's what's going on. Make sure that you put your hands on that patient and give them a good exam to make sure that you have a good diagnosis on it. There is kind of an interesting field developing now with osteoarthritis on biomarkers. It's being done from the urine, it's being done from synovial fluid and from blood. We don't know exactly what to make of it 100% right now, but it is exciting in the fact that it might direct further treatment options as you look at some of these biomarkers to understand what they may be doing to contribute to the osteoarthritic scene, particularly in the setting that you'll have somebody come in that has severe arthritis of their knee. They'll get an arthroplasty done and they may still have pain after. They don't always get better. And so trying to understand what sort of inflammatory component is additionally involved in their pain may be helpful for us in future treatment options, as perhaps just the osteoarthritis alone is not the only cause of their pain. I think one of the questions that comes up for us not uncommonly, I have a lot of patients that come in, their age, let's say 55, their knees getting a little bit of catching here and there. It's just sore, kind of wakes them up at night when they roll over in bed. And very frequently they're going to say, can I get an MRI? And my typical answer is no. I really don't think that an MRI is going to help them. And there are scenarios where that's a complete lie. There are scenarios where I do get an MRI because it becomes more necessary, but I'll kind of run you down my thought process on this. So number one, after the age of 45, the likelihood of developing some osteoarthritis becomes a little more likely. Past the age of 50, knee arthroscopy gets maybe a lot less beneficial than we would have hoped for. And getting an MRI usually only confirms that, yes, there is a meniscus tear. Yes, there is some cartilage wear and tear. There are signs of osteoarthritis present. And then what are you going to do for the treatment? So this is one of those questions of, does the MRI help guide your treatment in a way that's going to change or develop your treatment plan in a different way? The times that I'll say that that's different is I'll have gone and done, let's say, some sort of knee injection, and the patient may not have responded at all to that, or they have a substantial amount of pain with even simple weight-bearing activities that then do make me concerned that they could have a stress response in the bone or an insufficiency fracture. I just had a lady 2 weeks ago that came in. She was 75 years old. We had done She came in, she had some mild arthritis on her x-ray. She was going on a trip to Scotland and like, I've got to make it through this trip. So we gave her an injection. She got back from the trip and she's like, it felt really good for a couple of days, but it has not helped at all since. And it just seems to be getting worse. So we got an MRI and she'd had a previous femur fracture with a gamma nail down her femur. And when we imaged, she had actually developed a fracture that had spread from the gamma nail all the way down into the lateral condyle of her knee joint, non-displaced. So we were able to treat it non-operatively still, but helpful to have an MRI in that situation where I'd never seen that before, nor had my trauma team. We thought that was kind of an interesting stress response to have from that gamma nail all the way down. And then, of course, she goes through a bone health workup as well. Okay, so the typical response, and this is interesting, if you send somebody to the University of Utah and they're over the age of 50, really, and this is not a firm, it's still a case by case discussion on this, but over the age of 50, and you're like, hey, they have a little meniscus tear, it seems to be hurting them right where that meniscus is, but they're not really locking their knee when they're moving it. It's really unlikely that they're going to get a knee scope done. We typically reserve the knee scopes for completely or a knee that is completely locked up, meaning that they try to extend their knee and they just have this ridge and they can't get through it. If they have a knee that's completely locked up, then it's worth doing it. If they have a knee that is significantly catching where they can barely move their knee because it's just always catching on them, those ones, an arthroscopy becomes a more real deal. But if they have at least a moderate to severe amount of osteoarthritis, in those settings, our chance of having a recurring meniscus injury is really, really high. The research will show that they might get some pain relief up to 3 months, which is pretty consistent with doing a sham surgery as well, meaning that they still put a scope in, but they don't actually remove any of the debris from a meniscus. And then at a 2-year follow-up, people that have had the arthroscopy versus not really are in the same place. And again, that's inversely related to the level of osteoarthritis present. So you'll find a lot of people, I mean, there's some physicians in our area for sure that they'll say, hey, the knee is sore, there's a meniscus tear on the MRI, and pretty quickly they're getting their knee scoped, sometimes with or without an MRI. Is that a problem? I think it's very surgeon dependent and it's a judgment call on their part. But realistically, if you look at the evidence, it does not support doing an arthroscopy in the vast majority of settings. So if doing a knee scope is not an ideal situation or ideal solution, what do we recommend doing? And I think this is a fair question to ask, especially since people come in and they can be really, really bothered by the level of pain that they have. And doing a scope may not be in their best interest. And then getting a knee replacement is a huge step that they may, excuse me, that they may not be ready for. So one of the things that we talk to them about is weight loss. And that's assuming that weight is a component of their pain. But there was a good study done with knee osteoarthritis and associated weight issues. And they did an arm of diet, they did a study arm of exercise, and then they did a study arm that combined the two of them. Between them, the three of them, obviously the diet and exercise is going to win the battle. I'm sure you guys would guess that. But between diet and exercise alone, diet had more of a benefit on weight loss and on helping with knee pain. All endpoints did show benefit in the pain associated with their osteoarthritis, with them and being involved in these programs. So reviewing with them weight and its role into osteoarthritis is an important part. The way that I present it to patients, because I think patients can be very it can be a very touchy subject when you bring up weight associated with their pain. But I just say, hey, look, there's some things that you can help me that you can control with your pain, and there's some things that you can't. The osteoarthritis has multifactorial components to it, and so if you'll focus on your strength, if you'll focus on your weight, and if you'll focus on the types of activity that you're doing, those are the things that you can really help me out with as we're treating your knee osteoarthritis. And as we approach it that way, I think people capture it and understand a little bit more about their involvement in their care. And then I can work with them on the types of involvement that I can provide as well. As we're looking at the additional approaches, so there, you can do external bracing. An unloader brace is the one that has the best research associated with unicompartmental osteoarthritis. So if their arthritis is mainly in the inside or the outside of the knee, you can have an unloader brace made for them. Your local brace reps, and you just check with the DME that supplies for your office or with the orthopedic group in the area. But we actually have the brace people will meet them at their house, take measurements because they do have to be custom braces. And then they'll send those measurements off to the company and they'll manufacture a brace for them and then fit it for them. But they are, again, it's something that if somebody has a unicompartmental osteoarthritis, I'll do that. There's some patients that I'll choose not to do that for that still have. So I saw a patient yesterday that had pretty severe lateral knee OA, as is shown on this radiograph, and all of their pain was medial. And so I'd be worried that an unloader brace that's on the lateral aspect is going to just increase the force on the medial aspect and cause a little bit more discomfort for him. So I held off with an unloader brace for that patient. A compressive sleeve is not a bad idea for some people that just have generalized osteoarthritis. They have some pain, some discomfort. You can put a compressive sleeve on, which it helps increase the neuromuscular feedback so that it's a little easier for them to fire up their quad or their hamstrings. They don't have to wear it all the time, but they can wear it for comfort. It does not have a significant negative impact if they are wearing those. A hinge knee brace, sometimes I'll provide if they just generally have knee pain or if they have some sort of ligamentous instability associated with it, as that can help them have some improved stability. If they have an old ACL tear or additional ligament injury inside the knee, there are specified braces that could be used for those as well. It's not uncommon to see somebody, as I'm sure you're all aware, people that have had ACL pathology in the past have a higher risk for developing osteoarthritis. And many of them have gone through an ACL reconstruction in their teens or 20s or 40s or 50s or whatever it may be. And that may have torn since that time. So they may have some recurrent instability. Most of the time, as the level of arthritis increases, that instability decreases. They don't have as much instability associated with it because the motion through the knee starts to decrease as well. Good study done on just using an unloader's brace versus a sleeve for knee osteoarthritis. And the patients that had used the unloader brace, 18% of them at a year follow-up had gone through an arthroplasty versus the sleeve 36%. So it suggests that the unloader brace does help slow that process of people feeling like they need a knee replacement. And then NMES is neuromuscular electrical stimulation. They make sleeves that have electrodes in them and will stimulate the muscles. They're basically a means of helping people increase their strengthening in the setting of it hurts to fire up my knee. So we have a lot of patients that come in and they say, hey, I can't really move my knee or hurts and you're telling me to exercise. How do I do this? That's one trick that you can do. The other is blood flow restriction, which is BFR. It's often a lot of your physical therapy groups will now have this. It's basically just imagine putting on a tourniquet and then having somebody exercise. The blood, it's like a blood pressure cuff that you put on at the end of the day. There's different forms of them that are made, but it'll compress the pressure in the lower extremity, and then you have somebody exercise, and the fatigue level increases substantially with less force applied. So you can get a pretty good workout with applying a lot less force and a lot less weights to the extremity as they work out by having BFR in place. The research that we have for it is safe from what we've seen, including in people that have vascular diseases and heart diseases, et cetera. And so there doesn't seem to be a major contraindication to doing it in general. Again, case by case basis as to which patients you would apply it for, but it does help a lot of our patients that we do it with. Um, you can buy it like a home unit theoretically on those as well. Most of the time, I have them just do it with a physical therapist so that it's guided. And then if they like it and they find it beneficial, they can look at purchasing it for home use as well. Physical therapy does have good research associated with it. We know that it's helpful for knee osteoarthritis. There's a lot of patients that will struggle on just starting with land-based therapy, and it's going to be therapist dependent. Sometimes therapists get excited, like they don't know how much osteoarthritis a patient has, or they've seen the X-ray and it doesn't look like much, but they do have a symptomatic meniscus associated with their osteoarthritis, and they might start throwing them into higher level exercises. So we typically say, depending on how the patient is feeling and how they're doing, they may start off with like an aquatic therapy basis, and then as they improve, we'll transition them to a land-based exercise program. Even somebody that has pretty significant knee pain should be able to do isometric strengthening, which is where their knee stays in a single position, and then they're able to um, contract the muscle isometrically, and those can help start to build that strengthening. And then as they improve, we can start to increase through that range of motion and strengthening. Physical therapy, the downside is always a cost issue, compliance. I feel like there's a lot of patients that are caring for a spouse, may not be able to get to the physical therapy office, or they may have um, a weight issue that they don't feel comfortable getting in the pool, or there's always some component that makes it difficult. They may ask for home therapy to help them out with therapy. I don't have a huge problem with the home-based treatment plan, but often the therapist that will go to the home and provide that may not have the same background as the physical therapy office. So depending on what the patient's goals and mobility needs are, um, I'll typically push more towards a office-based physical therapist to work with them. But in some cases, we will use a home-based home health program. Um, at the end of the day, I don't care 100% about how they get moving. I just want them moving. There is research behind Pilates. There is research behind yoga. I'll just tell people, hey, if you're going to go do yoga, just put blinders on. I don't need you looking at the Gumby next to you that's bending backwards and showing how cool they are. You just go do it so that you're comfortable, and make sure that you're with an instructor that can give you specific instructions. So if you could not get into the position that they're instructing people to get into, that they can modify and show you a way to do it that does not cause some increased pain for you. Tai Chi, this is another modality that does have evidence behind it. Um, Smaller studies, but the ones that we have show some equivalence to PT. It also showed some additional benefits for depression and for quality of life. So kind of a cool approach that people can do on improving the strength, the proprioceptive control associated with their knee pain. And I love the mental health aspect of it too. Um, I mean, I preach this all day, every day, but exercise is medicine, and any form of exercise that we get does have some benefit for us. So just trying to help them engage in something that does not provoke them but helps them is incredibly important. Acupuncture, this is a lower level evidence. I think it was a level C, but there is some available evidence suggesting short-term benefit, even against some sham trials. So if they want to try an alternative method to it, I always say go for it. Pharmaceuticals, this is an area that will expand more as we understand more of the biomarkers that are contributing to osteoarthritis. We'll have better treatment options regarding the actual treatment of it. Right now, the mainstay level A recommendation is still for acetaminophen. So people will try that. I don't know about you guys, but I feel like when I take Tylenol, it's kind of helpful. Reduces the fever, but doesn't really necessarily provide a high level of pain relief for me on a regular basis. Anti-inflammatories do, but they all have their negatives associated with them. When you're looking at the anti-inflammatories, the COX-2 inhibitors seem to have a little bit lower risk of gastric issues associated with them compared to the non-selective ones. Of the uh, non-selective ones. The naproxen is a little better than ibuprofen, or has more GI effects than ibuprofen might when you're talking over-the-counter ones. Yes, it has a longer action or half-life for it, which is beneficial, but it may be more gastric irritating for patients. Naproxen, if you're talking about kidney effects, has a little bit less than an ibuprofen would. So you have to kind of select depending on what your patient's issues might be. Celebrex, ibuprofen, diclofenac all have increased cardiovascular adverse effects compared to your additional anti-inflammatories, but all anti-inflammatories have a potential cardiovascular effect for them too. At the end of the day, if you have a GI doc in the room, they're going to say, "Why are you ever prescribing long-term anti-inflammatories?" And so I really try not to. But it is a discussion to have for patients based off of availability of additional pain modifying measures, and then making sure that you are monitoring those medications and how they're taking them. Typically, a short course of an anti-inflammatory is the best way to prescribe it, or a very occasional PRN usage. But I will prescribe PRN usage, and then somebody comes back and says, "I'm using it every single day," in which case then I'm trying to maximize my additional conservative care options so that they don't feel the need to take medications on a regular basis. I will pause for a second if anybody has a question, if there was anything that's come through.
So far, I'm not seeing anything, but if you do have a question, please put that in the chat and we'll ask it for
Okay.
you. Thank you.
Okay, sounds good. All right. Here in Utah, we have all these really cool companies that people somehow get involved in this. It's probably not a pyramid scheme, but it's like there's a base level and then it kind of builds up from that base level and then it keeps building from that base level and something that looks like a triangle. Um, but at the end of the day, there's a lot of these essential oil companies. It's becoming less of the cult that it was for a while, but there still is a lot of discussion about uh, alternative medications, which I think it's reasonable to at least address because there are benefits to some of these medications or oils or whatever they may be that patients will take. Um, the trusted and true tried ones are the glucosamine and chondroitin. Those have been studied for decades. And it's unfortunate that we don't really know if they help or not still, despite all the research done on them. Turmeric has become one that people have started to use much more. MSM, SAMe, ginger, all of these medications do still have some level of research associated with them. It's just been unclear over the years as to how much they help people. I will usually say if they want to try a glucosamine or a chondroitin or a combination of the two, by all means try it. Try it for about a month. It takes about a month to see the full benefits. It'll cost them 30 to 40 bucks a month in general. And if they benefit from it, great. They can continue taking it. If after a month or two they're really not seeing the benefit, then I'm not going to encourage them to continue to do it. One of the questions for them would be, am I actually preserving my joints? And we don't have evidence that they necessarily would be, despite the fact that they might be repleting the chondroitin or the glucosamine component, which would be hopeful that you would have long-term benefit. Turmeric has more of an anti-inflammatory effect, and some people do benefit from taking that as well. So no major issue. It's always nice to know. I always ask them, hey, just make sure you let us know what those are. As you know, some of them can be have an effect on bleeding or other components that affect their healthcare. So even though they say they're natural, it does not mean that they are not a medication at the end of the day. It just means that they're not being regulated by the FDA. Patches, there are topical patches that people can use. There's NSAID patches, like a Flector patch, which is a diclofenac patch. They tend to be really expensive. Why? I don't know, but they're very expensive. The only people we actually really use them very often for are like the jazz players, just because the jazz will pay whatever price it is for those patches. Um, but some patients, if they're tiered in a way that their insurance will help them cover them, I don't have a problem with them trying those things. There is still a systemic absorption associated with it, but the systemic absorption is much lower. Lidocaine patches, you can do a prescription for Lidoderm. And it's, well, I think that's a 5% lidocaine, or you can have them just buy Salonpas, which are a 4% prescription. Either way, the patient wants to try it. I usually have them just try an over-the-counter version first because they're so much cheaper for them, and they don't get as much grief from their insurance program. But some people will find benefit if it's a more superficial source of pain to throw a lidocaine patch on there. Creams, capsaicin cream is one that has to be applied on a regular basis. It helps waste the substance P, which is one of our pain components. And if it's not applied on a regular basis, that substance P still accumulates. So if they're going to use a capsaicin cream, just some regularity to its usage if they want to actually see benefit from it, it's important. Diclofenac gel, as you guys know, has gone over the counter. So a lot of people have found that and tried that. And it can be quite helpful for some patients. I think the nature of how superficial their pain is plays into that one. And then they do make versions of diclofenac that have like DMSO in it, which helps it penetrate deeper. I think that's called Penzed is the formulary of that. Again, very expensive as soon as you add some DMSO into the bottle. So a lot of patients will not want to pay for that. Compounded medications, I think they were pretty hot maybe a decade or two ago. They're slowing down on how beneficial or how often they're done just because the research hasn't yielded the same results. But if people want to try them, I don't have a huge issue with that either. Again, just making sure that the medication profile in the compound is okay for their comorbidities. Then we'll move on to injectable options. So injections, there is a chondrotoxicity or a risk of damage to cartilage associated with injections. When you're talking about anesthetic, the only anesthetic I put into joints is ropivacaine. Ropivacaine is the least chondrotoxic of our available medications. Marcaine has the most chondrotoxicity to it, followed by lidocaine, and then much less so by ropivacaine. I use a 0.2% ropivacaine for all intra-articular injections. It is more expensive. It's not I mean, I think it actually is a decent amount. If I remember right, the last time I looked, it's like $10 versus $1. So it is not a substantial amount, or it is substantially more expensive. However, when I'm looking at what I'd want in my knee joint, ropivacaine is just going to be a safer option for people. You can check with your formulary to see how much it might be if you were to switch and do that. But I'd advocate not to put Marcaine into a joint ever if you could help it. Corticosteroids, again, they do seem to have a chondrotoxicity associated with them. There's variable research on this. There was a recent research project that came out and argued that there was not chondrotoxicity associated with it. I've done way too many injections to feel like there is not some associated chondrotoxicity because I'll see rapidly progressive osteoarthritis on some patients that we have done corticosteroids versus other ones where we don't see that. Benefits seems to be somewhere between 1 and 24 weeks for most patients. I'd say on average, we'll typically see 3 months is not uncommon. There is always the question because a lot of our research has been done against the control of saline, and it seems that saline itself just has benefits. So, people will talk about prolotherapy, which is often a dextrose component that's placed into a joint, and prolotherapy does seem to have some benefit associated with it as well. Triamcinolone is the typical corticosteroid that I use on the research, seems to have the most benefit when placed into the joint compared to the others. However, sometimes I've done like a triamcinolone injection and they have not had enough benefit, then we'll switch and use methylprednisolone or depomedrol and see if they have more benefit with that. The more precipitant, dense corticosteroids seem to have more longevity when placed into the joint. Hyaluronic acid injections. So this is, I guess controversial at some point. Obviously, the AAOS came out, I don't even know how long ago it was now, probably 7 or 8 years ago, and said, or maybe even longer, and they said, hey, we actually don't think that this helps joints, and therefore we don't recommend its usage. And everybody freaked out because many patients have benefited from HA injections in the past. And the AMSSM, which is the non-operative group, came out and said, hey, we actually do find huge benefit with this, and the research does not support what the AAOS came out and said. And so there's kind of a dispute back and forth as to what should be done with this. And at the end of the day, if you look at the research on HA, it is beneficial. It's not a perfect capture rate as to who benefits from it. Therefore, insurance quickly jumped on board with the AAOS statement and said, well, if they said it's not beneficial, we're not paying for it anymore. So it's per insurer, very interesting who pays for it and who does not. But HA is a component of our cartilage as well as our synovial fluid. And when you develop osteoarthritis, that synovial fluid, the hyaluronic acid substantially diminishes and thins out. So putting back in some of that hyaluronic acid into the joint often seems to help people. It does help more for people that do not have an effusion at the time of the injection. So if I do an injection and they have an effusion, I will pull that off, take the fluid off, and then place the HA into the joint. If you're using Synvisc, which is an organic version of hyaluronic acid, it's from a rooster's comb. It does have a potential for a pseudoseptic reaction, which just means that everything looks like it gets infected, gets red hot and swollen, and everybody freaks out. And then it will self-resolve usually within a week or two. If it does occur, I still bring the patient in, I still aspirate the joint, I still send it off to the lab to make sure that it's not infected. It comes back being highly inflammatory, but does not grow anything. And we just watch it. I will often put a corticosteroid in the injection to begin with if I'm concerned that they're going to have a pseudoseptic reaction. Pseudogout is another situation where we'll look at it, and if they show some chondrocalcidosis or concerns for pseudogout on their imaging, there is a known chance that they can have a little bit increased risk of a reaction to hyaluronic acid. So if they have pseudogout, I'll just kind of review with them that they have a slightly higher risk of having a flare of their pseudogout. The other medications or the other brands that we'll use for injections into the joint are usually synthetic versions. They'll make them in single dose vials. They'll make them in 3-dose vials. They'll make them in 5-dose vials. I'd say whatever you're comfortable with is fine. I typically just do the single dose vials because I don't want patients to come back in multiple times on a regular basis. I think it's just a little bit more obnoxious for them to have to do that. The research doesn't show that 3 is better than the single versus 5. All you're doing if you're doing a single dose vial versus a multi-dose plan is adding it all in at once. So 6 cc's instead of 2 cc's over 3 weeks. I will do the multi-dose vials if I have somebody like Uflex is often a backup one that I'll use, and that's just I'll make that decision based off of a patient's tolerance to volume of injectate or a previous benefit from one type versus another. Injection technique we'll discuss real quick. There's a lot of ways to approach the knee joint. Whatever approach you're comfortable with is your right answer. But if you look at the success rates by the numbers, usually a superolateral or a superomedial approach to the joint is the best, which means that you're just going kind of at that level of the kneecap or slightly above it and injecting from the side into the joint. Tends to help make sure that the placement is correct. Downside of that one, as you can see on this list, is that you can hit the patella and theoretically could damage cartilage if you're really jabbing in there pretty hard. A lot of people will use an anterior approach. Again, if that's something that you're comfortable with, that's fine, but it does have a lower chance of being into the correct spot on a regular basis. And then it's also harder to potentially aspirate because a lot of the fluid does collect in that superior synovial recess, just a little bit higher up on the joint. Imaging modalities. So we will do injections under ultrasound guidance. I'll choose to use ultrasound guidance primarily on patients that have a very large body habitus. That way I can make sure that I'm perfectly in the joint, or I'll do it on patients that I'm using a more expensive injectate on just to make sure that it's perfectly placed and certainly within the joint. But the majority of my injections I'll still do without imaging guidance, just to help save on cost for patients. Um, Accuracy when using an ultrasound is obviously very, very high. It is highly user dependent as far as accuracy of placement. Just because you have an ultrasound on it does not mean that you'll be in the right spot if you don't know what you're looking for. I'm assuming there might be some of you that do more ultrasound than others, and if you use ultrasound for placement, that's great. Um, it's worth going through some of the cell therapy options because the advertising that people hear is pretty crazy. People have come in, and because the treatment with cell therapy is all cash based in the United States at this point, or almost all cash based. I'll review that in a second, but there's um, a huge push for people to go to clinics throughout Utah, throughout Colorado, throughout the US, as well as going into Mexico or any foreign country to get these treatments. And so I get this question a lot, and we work with patients on options for it. But the advertising, they suppose that there is a holy grail out there. Just to cut through it real quick for you, there's not a holy grail. There was a well done research project that came out earlier this year that compared different versions of, I'll air quote, stem cell treatment and amniotic fluid treatments, et cetera, looking with an MRI before the injection was placed, looking at an MRI months after the injection was placed to see if there was actually cartilage regrowth, if we were regenerating a joint. And the short answer is we're not. The longer answer is that we are seeing benefit from it. So we are seeing that people do get some pain relief and some improved functional measures. So there is something to this, but the overall, what would we really hope for from it? We would hope that we're able to reverse arthritis, and we have not seen a reversal of that at this point. Let's talk about what it is. So when we say stem cells, what we're really doing, if you're talking about what a stem cell is at the end of the day, it's something that can divide and become basically anything that we want it to. If it's a pluripotent stem cell, and then it gives rise to additional cell types. In the US, when we're talking stem cells, what we're really talking about is typically bone marrow aspirate concentrate, or BMAC, fat derivative, or we'll pull from the blood more in the setting of PRP. While you will find that these do contain some stem and progenitor cells, the vast majority of what you're pulling off is not that. They're the least abundant cells in the preparations present. So I think there's always this idea of how do we get more stem cells? The embryonic stem cell is how you really could get a pluripotent stem cell at a much higher quantity. And ethically, that is not something that's done in the United States. So because of the fact that you're getting very few stem cells, typically we refer to it more as a cell-based therapy at this point, rather than a stem cell therapy. It's just nomenclature reasons, but I think it's important that people at least understand what they're getting when they're receiving these products. PRP, a little more specific as to what the research is most supportive of. So there's a high level of research done on PRP at this point. Stem cells have research, but again, because it's a cash pay, it's a business opportunity for people, the research has lagged well behind clinical usage. In fact, the laboratory evaluation of these treatments has also lagged behind clinical usage, again, just for the fact that people are not incentivized to do that research as much as they are to provide the treatment because people are paying cash for it. PRP itself is a blood draw. That blood is put in a centrifuge and separated, and then taking the platelet, or taking the plasma component that has the most platelets in it, and then re-injecting that into the joint. It does, if you look at it on a day-to-day basis of drawing PRP off of a patient, the same patient, it'll vary based off of a lot of different factors that occur through the day for those patients. And it will vary in the growth factors, the mediators, the leukocyte count, et cetera, based off of what you're drawing off every day. There are a lot of systems that can be used for PRP, and they all have, very interesting levels of what you're actually pulling off with these systems. I'm highlighting a couple things. You could use the GPS system, and it requires 54 cc's of blood that you pull off of a patient, versus the Arthrex system, which was 11 cc's that you're pulling off. And you may get 10x increase in platelets off of one system when you're pulling that fluid off, versus another system where you might only have a 1.3 times amount of platelets from the initial blood draw. So huge variations in what each system will actually do. This has been part of the confounding components of our research, trying to figure out what type of PRP is the best and how to use it the most effectively. Is that there's so many variations in the preparations. We just recently did a project at the university using, instead of a kit, we did a technique where we just drew the PRP off ourselves and spun it down, trying to prove that we can make low-cost PRP. That project will come out or be published sometime soon. Just going through the review process right now, but basically trying to propose that there is no need to charge these exorbitant prices for cell therapy treatments, that we can do it for a cheaper cost and still have the same benefit. Some of the complicating factors of PRP, there's a lot of manufacturers of these kits, independent preparation. Like I was telling you that we did, there's a question of, do you keep the white blood cells in the preparation or do you remove them? How do you activate the PRP prior to the injection with either calcium or thrombin? Again, those platelet concentrations vary a ton, and then there's a whole bunch of other factors associated with age and health and sex, time of day. And it just makes it hard to interpret it and figure out what the best answer is. So at the end of the day, with all of that confusion, why are we doing it? It comes down to there is level 1 evidence to support its usage in mild to moderate OA. Once somebody comes in and they have more advanced OA, I typically will steer them away from it and say, hey, this is really not worth it for you. Of the research we have, it seems that if we remove as many white blood cells as possible, it may be more efficacious. So a leukocyte poor preparation of PRP seems to be better. The long-term efficacy is still unknown. If you just quickly look at the hip, we don't have as much data. The knee is the level 1 evidence area. The only insurer that I've run into that will pay for it has been TRICARE, and TRICARE has paid for it on a single injection for their patients. So they'll let them have it once. I'm proud of them for at least doing that. But beyond that, no other insurer that I have seen is allowing it on a regular basis. Amniotic fluid, we'll just briefly go over this. There's not a lot of evidence to support usage of amniotic fluid. Extended release corticosteroid, there's a medication that we'll use called Zilretta. It is triamcinolone, but it's formulated in polymicrospheres, and so it just has a slow release. We did a research project on this one as well that we published a couple years ago, and it was pretty cool in the fact that people that had even stage 4 arthritis would still get benefit 3-4 months out. So it is something that when people have failed other measures, we'll often use Zilretta. A little bit more onerous in usage in the fact that it has to be refrigerated, and it's a vial that has to be, it does not come with just a single draw vial. You have to do a mixture to prepare it, but beneficial. Unfortunately, insurance is only or the research has confirmed that a single dose of it's safe. Multi-dosing, meaning they come back to do it repetitively, has not been researched as well. And so a lot of insurers will only pay for it once. Other insurers are allowing it on multi-dosing as well. Other injectable options, you'll talk to patients that have had ozone or prolozone done through their chiropractor. They'll hire a physician that comes and does those. It's been around a long time. Again, because it's cash pay, there's not been a lot of good research on it. So there's a strong bias in almost all the research presented. But it does appear to be safe, and some people will find it beneficial. So if they do ozone injections and it helps them, I don't have a huge issue as long as it's being done by somebody that is competent in what they're doing. We'll end on a case presentation. So this is a patient I had, 78-year-old male, chronic right knee pain. Was scoped years ago. He has a history of cortisone injections that provided some relief. He's had a hyaluronic acid injection without any relief. The corticosteroid unfortunately didn't last more than a couple of weeks. He does use Tylenol and occasional NSAID, but he has a history of hypertension and coronary artery disease. So his primary care says, hey, you probably shouldn't do the anti-inflammatory. He does have Parkinson's and some other complicating factors associated with his care. He had a total hip and he did have a blood clot after, so he's pretty anxious about not moving on to do a replacement anytime soon associated with that. He is a pretty nothing on physical exam that was highly concerning. His BMI was a little on the higher side at 32. He has a clear varus deformity, which means he's a little bit bow-legged, which tells me that he has medial compartment OA. He walks with a limp and he's pretty tender over that medial joint line. Range of motion's slightly reduced. 0 is neutral, so he does not reach a neutral. His neutral is actually at 15 degrees of flexion, and then he can flex down to 120 degrees. That's his X-ray. With this history of the DVT and all the complicating factors that we talked about, we said, all right, let's get you into some therapy. Let's get you strengthened up, work on some motor control training. He was fit for a motor brace, and we did a Zilret injection. At a 3-month follow-up, he got 2.5 months of pain relief. He's wearing the brace, but not consistently because it does get uncomfortable when you're wearing it for long periods of time. He's finding PT to be helpful. Offered him a repeat injection, surgical consultation, as well as the possibility of an ablation. He saw a commercial since I last saw him. The amazing commercials that help direct people on what they need in their lives. And he said, hey, what about doing an ablation on the knee, which is a procedure. There's multiple nerves around the joint that supply sensation for him. Some of those nerves are also motor. And so if it's a motor nerve, you cannot go in and ablate those nerves. But if it's a sensory nerve alone, you can go in and, like you would on a back with a radiofrequency ablation, you can do ablation on these nerves. Some of those nerves, the ones that we'll typically target are the superolateral genicular, the supramedial genicular, the inframedial genicular. Sometimes we'll go back and do the infralateral genicular nerve. And then often we'll hit the nerve to the vastus lateralis and vastus intermedius and vastus medialis because they don't have as much motor supply associated with them. This is what the procedure will look like. It's done underneath typically fluoroscopy. We do use X-ray sometimes to place the needles, but fluoroscopy makes it easy by bony landmark alone. And results of it benefit for usually about 6 months in at least 50% of the patients that it's done. It's very imperfect if you're looking at that. The numbers in comparison, benefit at 6 months was 16.2% in the intra-articular steroid group versus it was reported on this article at 74%. As the numbers have borne out over the years, our response rate to doing an RFA is about 50-50 for who benefits, and we're looking at least 50% improvement in pain. So it is an option. It's no miracle. Something that is at least helpful to have as an additional component to treat patients. And then there's the arthroplasty. People will come in sometimes with just a unicompartmental osteoarthritis. They'll hope to have a unicompartmental arthroplasty performed. They'll come out of surgery and have a full replacement, mainly because that decision is often made at the time of surgery. The cartilage will be evaluated on both parts or on all parts of the knee. And if it's deemed that there's large cartilage defects that could not be seen on an X-ray, they'll convert it to a full replacement. There's always controversy on if you're doing a cruciate sparing or not. the who, the where, the when. It's not an easy answer to give people if they want to become partially a cyborg or not. Um, but it is a discussion to have with patients when conservative measures are otherwise failing. So my approach will typically start off with medications, modifications to their lifestyle, physical therapy, bracing. We'll talk about a corticosteroid injection. Depending on their level of osteoarthritis, I'll try not to do a corticosteroid injection as a regular or first option and offer something along the lines of PRP or hyaluronic acid instead. If people have tried the other measures and it's not helping as much, I'll often have them try Zilretta, the extended release triamcinolone. We'll talk about a radio frequency ablation of the knee, and then move on to an arthroplasty if nothing else is helping. I think that covers my part of it. I've done enough yapping. By all means, I'd love to hear any questions you have.
Excellent job, Dr. Monson. Thank you so much. If you have a question, please put that in the chat. We'll read that off to everyone. And while we're waiting for just a minute, reminder, not next Friday, the 8th, but the 15th will be the next presentation by Dr. Monson again on acute injury management. So please be sure to join us for that. And I'm not seeing any questions coming in.
Okay. They're all asleep. That's why.
From Dr. Arja, yes, great job. Thank you. From Terry Ahern, thanks, very helpful. Thank you so much. Sarah Scott, very helpful.
Okay.
All right. Thank you,
Great.
everyone. I'm going to call it at this point. We'll be sending out evaluations right after. Thank you again, Dr. Monson. Excellent job. Lots of great information. And enjoy the first day of November, everyone. Have a great day. Thank you.
Thank you.